All right, we're going to go ahead and begin. This is chapter 13 in your Rollins textbook, and the chapter theme is breathing. Some of the most common health problems in childhood are related to respiratory function, with respiratory infections accounting for the majority of acute illnesses. Respiratory distress is the 8th leading cause of death in newborns, with pneumonia ranking in the top 10 causes of death. When designing activities for children with airway impairment, it's wise not to overstimulate their already compromised and delicate respiratory system. It's important for children who have respiratory problems to have information about their illness. Therefore, activities can be tailored to increase understanding and education. Respiratory problems can be caused by trauma, disease, or physical anomalies. So in understanding respiratory problems, asthma, a chronic disease characterized by recurrent attacks of breathlessness and wheezing, is the most common chronic disease among children, according to the World Health Organization. Although the cause is unknown, it is thought that genetic predisposition and environmental factors play a significant part. Feelings of isolation and loneliness are common when unable to keep up with your peers. Fear of death is also common. Irritants in the environment may exacerbate symptoms. Things like pet dander, vegetation, toys, dyes, secondary smoke are possible irritants. Another disease involving the respiratory system is cystic fibrosis. This is an inherited disease which causes the individual to cough, which is a protective reflex. Environmental factors. The most recent environmental factors, or rather more recently, environmental factors have become a growing concern for children's health. Things in our environment, in the air that we breathe. Secondhand smoke has been found to cause adverse respiratory consequences, including early onset asthma. Secondhand smoke increases coughing and wheezing, airway obstruction, airway hyperactivity, and bronchiolitis. Another risk factor is sudden infant death syndrome, or SIDS. According to Fleming and Blair, Pollock, Weisberg, Kessmodel, Henriksen, Olson, and Secker. Post-operative respiratory problems can occur because when a child experiences anesthesia, everything goes to sleep, including our lungs. They are more passive in respiration. And therefore, unless we get a child up and moving about and get everything working again, breathing is strong, and they have bowel sounds again, then it helps to minimize the possibility of a respiratory infection. And this is always a potential complication after surgery and often attributed to the anesthesia. When the throat becomes dry, mucus can cause plugs that put the bronchi or bronchioles in danger. The cough reflex can also be depressed by pain medication or anesthesia. And the child is reluctant to cough because it could be painful or perceived as being painful. A blockage in the bronchus or bronchioles may collapse a lung lobe called atelectasis. When mucus secretions cannot be moved by coughing, infection can occur, causing complications. Aspiration pneumonia may occur when vomit comes up the esophagus and inhaled into the bronchial tubes. Obesity, according to Fiorino and Brooks, report that obesity is a growing concern and contributes to respiratory distress. One reason is because when an individual gains a significant amount of weight, they also gain weight in their neck area. And when they go to sleep, it puts strain and stress on their esophagus and their epiglottis, which is when the esophagus closes and opens with breathing during our sleep. The impact of obesity on respiratory disease can further be characterized as the impact on pulmonary mechanics. It can be linked with and impact asthma, and it can create a risk factor for sleep disordered breathing. One study found that obese children have more severe asthma than normal weight children. Another study found that obese children with asthma reported more medication use. And a third study linked a greater use of emergency departments for obese asthmatic children. In continuing with this theme of obesity, it is thought that several factors contribute to the association between obesity and asthma. Asthma may create a psychological barrier to exercise, rendering children more sedentary, putting them at risk or greater risk for obesity. Other issues include mechanical factors, gastroesophageal reflux, that burping up after you eat or drink something, and hormonal factors. So how do we treat respiratory problems? Young children may be unable to describe difficulty breathing or dyspnea, and may exhibit lower exercise tolerance and shortness of breath with activity. Children with asthma or cystic fibrosis exhibit reactions when they breathe, such as grunting or nasal flaring. These children are often seen for repeated hospitalizations. Some treatments are time-consuming and expensive and unpleasant for the child, which fosters stress and anxiety. Children with respiratory distress may require a nasal cannula for administering oxygen. They may have altered nutritional needs, with difficulty eating during acute episodes, and hydration is essential. Increased hydration prevents mucus from becoming too thick. Children should be encouraged to drink favorite fluids at frequent intervals. Children with respiratory problems may require quiet rest times during the day to rest. Each child's pain experience is unique and subjective. Children with cystic fibrosis may exhibit a barrel chest, pallor, short stature, and clubbing of the fingernails and toenails because it is difficult to get oxygen all the way down to the very tips of their extremities. They may view their bodies as inferior because of physical limitations and need strategies to help them cope with difficult situations. Play activities promote incentive to comply with medical treatments and to relieve stress. Some special considerations. Care must be taken to use appropriate activities with activities for respiratory patients. Following any use of general anesthesia, Respiratory exercises promote alveolar expansion and exchange of oxygen and carbon dioxide are usually encouraged. Deep breathing, taking deep breaths, blowing out invisible or imaginary candles, blowing bubbles. Deep breathing and coughing help prevent pneumonia after surgery. Children may be reluctant to exercise because of fear of pain and concern about opening the surgical incision. Deep breathing post-operatively is usually painful, but this can be facilitated with hugging a comfort pillow or stuffed animal used as a splint to the chest. The activity for this lecture, it involves blowing up a balloon and playing catch or toss with the balloon by hitting it back and forth, okay? Or blowing out bubbles, blowing bubbles rather. Another activity could be using a straw to drip watercolor paint on a piece of paper and then using a straw to blow the paint around on the paper. Either of these activities are accepted for a breathing chapter, okay?